Welcome, and thank you for joining us today from various patches of the planet. It's good to share time and virtual space with people who care so deeply about children and also budgets. My name is Gillian Hubner, and I lead the Collaborative on Global Children's Issues at Georgetown University in Washington, D.C. The collaborative works in partnership with child-centered leaders across the globe, including the experts you will hear from today. We are gathering at a time when budgets and programs for children are being drastically cut. In recent months, we've seen the decimation of US government foreign assistance programs that supported the world's most vulnerable children. We are seeing similar cuts on the domestic front in the United States. And of course, all of this has ripple effects across the world. So how do we continue child-centered work in the world in the midst of these realities? Budgets are one way to check values, to measure what we care about. Our public finances tell a story, but the children's side of that story is often buried under the headlines. It is my honor to introduce today our moderator, Shar Qurtishi. Shar is a seasoned expert in public policy and finance with over 20 years of experience, including a decade specifically focused on public sector finance for children. Shar has worked globally to generate evidence for underfunded strategies supporting children's rights across sectors like education, health, social protection, and child protection. His international portfolio includes assignments in over 30 countries across Europe, Africa, the Middle East, and Asia. He holds an MBA from IEDC Bled School of Management in Slovenia and is currently a fellow with us at the Collaborative on Global Children's Issues at Georgetown. Shar, thank you for organizing today's conversation. We look forward to learning from you and your colleagues about child-centered public finance. This webinar will run an hour and a half. Feel free as audience members to share questions in the Q&A, and Shar will manage these and facilitate a conversation as we move forward. Thank you all so much.
Thanks everyone who's attending online at the different time zones. Thank you the organizers, Gillian, Jan and Carrie for making this platform available at this time around when the funding have been cut severely from the development partners around the world. So I think it's a great timing to have this for all the practitioners out there, for all the decision makers and policy makers around the world. And hereby, please join me in welcoming our today's distinguished speakers. Dr. David Akpan, he's based in Abuja, Nigeria. He's an epidemiologist by profession and a development expert whom I had the chance to work with for 18 years now. He's a public health specialist, so he has successfully directed projects, multi-million-dollar projects in areas of health promotion and prevention, health system strengthening, social protection, and public health emergency. Also, I'd like to invite Zuzana Firganova. She's based in Bratislava. She's a development professional with over 6 years of experience in policy and advocacy across sectoral partnership building and local governments. She just concluded her work as a community partnership advisor with UNICEF Slovakia Refugee Response Office, and she'll be talking today to you about Slovakia's response to Ukrainian refugees and children as well. Welcome also Ms. Fikr Salam Getinet. She's based in Addis Ababa in Ethiopia. She's a dedicated development professional with over a decade of experience in gender equality, girls' education, child protection, and social protection. She currently serves as a girl education specialist at UNICEF Ethiopia. The work that we're presenting today she's presenting today is about a national strategy that has been endorsed in Ethiopia on female genital mutilation and also ending child marriage. Please also welcome Ms. Neha Singh. She's based in India at present. She's a sector co-lead with Save the Children Syria's Response Office based in Amman. With over 15 years of experience in humanitarian health system strengthening, Neha spent the past 7 years deeply engaged in Syria response, leading the key initiative across health and nutrition. Her leadership has guided the development of nutrition sector response strategy, essential health services, WASH and nutrition program, as well as cash for nutrition pilot in both northwest of Syria. Her broad and humanitarian work includes also missions in Afghanistan and India, left-wing extremist affected regions. So thank you. Briefly, I'll introduce the flow. I think we can do some housekeeping. I guess anyone from the team would be able to do that. Jan?
Yeah, sure. Any details that come up, Gillian has mentioned most of the housekeeping, but anything else will be shared through the chat box. Participants are welcome to share their questions through the Q&A function, and we'll keep an eye on those. And like Gillian said, this is going to be a 90-minute conversation. Presentations will start, and then we'll have time for dialogue following that. We'll be updating you through the chat box.
Thank you, Jan. So let me carry on with the first presentation and just share the screen quickly. Let me start by saying that why we think it's important to invest in children. The fact that just give me a second. Sorry about that. So children and young people today are not only our future citizens, but they are also active members of today's society. Realizing that children's rights, like any other investment, comes at a cost. Children who make up more than 30% of the world's population, they have the right to education, health, social support, access to legal system, and protection from violence, abuse, among other basic rights. So adequate resourcing and necessary to realize the civil rights and freedom of children, including the rights to participation and information, and to an important contribution to the development of the society. I always highlight the famous James Heckman's novelist saying that we can't afford to postpone investing in children until they become adults, nor we can wait until they reach school at a time when it may be too late to intervene. And he also has a study. There's been growing evidence, but the most compelling one is for every $1 spent on quality childhood programs, there is a return, a 17.01 return in cost savings, which goes to 12.9 to the public and $4.17 to individuals. So any return on investment which outweighs the investment, it's a worthwhile investment. So to do that, we have to start with the CRC, which is the Convention of Children's Rights, and SDGs, which are measured when it comes to children rights. So it's important and it's imperative to provide adequate investment that enables children to thrive. And to do that, you have to invest. Governments have to invest in order so that those children of today become adults, our future adults of tomorrow, and they would become part of society. The international community has recognized this through an obligation under the Convention of Rights of the Child. So Article 4 of Child Rights Convention requires government to undertake the measures to fulfill children's rights to the maximum extent of their available resources. We know that there are constraints, but still, I think we have to make sure that we put children at the top of the agenda. There are 5 dimensions that I would like to highlight on children's rights. So for every child to thrive, to survive and thrive, you need to have no stunting, no wasting, or no overweight. So with that, I think we take care of also SDGs implementation, which is no poverty, zero hunger, clean water. And then also SDG 3 stands for birth attended by skilled personnel, under 5 mortality, reducing under 5 mortality, neonatal mortality, and reducing the HIV infection of children under 5, adolescents, boys and girls between 10 and 19. We will have a speaker that would speak about nutrition, Ms. Nea, and David, who would speak about the case of Nigeria on children living with HIV and the treatment that they've been receiving. Minimum proficiency in education, so quality education. It's important that they receive, and I just mentioned the Heckman's curve, that the earlier we invest, the better off we stand as, and there are losses that government would take at a lower rate if invested early and wisely. We can prevent violence against child violence against the children at all, overall, mitigating harmful traditional practices, child marriage, female genital mutilation, and we have a case study for it in from Ethiopia's case, which Ms. Fiker will present in a short while. And then we have basically other topics that we're going to discuss are also the issue of refugees, an important topic where the case of Slovakia, whereby how they have been handling the refugee population that were coming from Ukraine, those passing through, but also those residing, and their rights. When it comes to social and economic returns, I think there are multiple reasons to invest in children, but fundamentally is to ensure that the realization of their child rights is done at the right manner. So childhood is a unique opportunity, a unique window of opportunity. So there will be no other childhood. So investing the earlier the better. So the benefit far outweighed the costs. Knowing the fact that again, the evidence is up and coming and it's growing, but there are tangible losses at the individual level, but also at the community and also at the government level if we don't invest wisely for children. And there is a slide later on that I will show on those figures. So early childhood has been a benefit to and it has been proven that it's a wise investment. So to break the poverty cycle or prevent it from beginning, it's important to invest in children and their childhood. So when we talk about investing in children, a lot of times we see that almost all the countries, they invest in response, in treatment, and not in prevention. So, and noting the fact that prevention is the key and it's less expensive than the response. So having plans and strategies of to respond to child rights and children, embed child rights and child protection within the multi-sectoral approach, I think it helps and it will be less expensive. Appropriate health care for women improves birth outcomes. Early stimulation activities in school cost less than high dropouts at the later stage and repetition rates later on, either in primary or secondary or even later in higher education. So early investment leads to increased productivity in the school, but also in the workplace later when those children become adults. Support to children potential development to become a well-prepared adult for life. I think that's the key to investment. When it comes to return on investment, I have a saying that there is no greater investment than investment in children. The only investment that doesn't depreciate. Everything else depreciates. So I agree with Mr. Heckman, and evidence is showing that too. So let me show you some examples. So on investment cases that were done for children. Increasing preschool enrollment found benefits in terms of higher future wages of $6.2 up to $17.6 per dollar invested, and can provide a long-term benefit to the countries. A one-year improvement in population's life expectancy is associated with 4% of increase in output. And this can be huge, especially for those countries that have very young populations. The loss in adult income from being stunted, underfed, could be up to 22% for that child when he enters or she enters the labor market. Eliminating anemia could cost between 5 and 17% increase in adulthood productivity, which means that later in the life there will be less cuts across the lifespan of that individual attending healthcare, and that would have an increase in productivity. So the average rate of return to education is estimated to be around 10% globally. From the public finance perspective, there is the way government uses financial resources to achieve its policy objectives. We can't say that there is no money for child rights, but if it's sufficient or not, we have tools to measure that. Through public spending with available resources and macroeconomic goals that we do on public finance for children. So resources are allocated effectively between different areas and items in pursuing development goals. However, sometimes they tend to go into response and not prevention, which happens. And that brings us to a question: are we using that money wisely? And we have a value for money that we use to assess that. I don't want to go into details on value for money. That's a pure public finance management tool, but it checks the cost efficiency, the cost effectiveness, and cost benefit analysis, and eventually you can do a cost of inaction analysis if it's not a value for money exercise. On the service delivery chain, you put the money in, you happen to buy some inputs, so meaning personnel, services, and which turn out into a process or activity, and then turned into output and service delivered to beneficiaries, and ultimately an outcome and impact that would have an impact at the individual level, but also at the government level. So when we look at the public finance for children model of generating evidence, we tend to check the policies versus if they're connected to sectoral plans. If those children policies and sectoral plans are connected to the budget allocations, if the budget is really flowing it's approved, and if it's not in the budget, it's not going to happen. So no expenditures will take place. If it takes place, then obviously we carry a lot of analysis, budget analysis, public expenditure tracking surveys, CPAM, and various analysis to ensure that, because children are not a sector on its own, so in order for us to assess where the budget is, you have to analyze across different sectors. And we have the example later on in Ethiopia and Slovakia as well. So all in all, public finance for children is a model that is used to generate evidence because of there is no specific sector for children in most of the countries around the world. So we tend to go in and scrutinize the different projects, different activities, and then that would make up the financing for children. Keynotes on investment for children and action and cost of inaction as well. So at the individual level, there are gains and losses. So gains, for every $1 investment, there's a yield of 4 to 13 in return, higher earnings, improved health, and reduced crime, and the list can go on and on. On the other hand, children receiving quality education are 25% more likely to graduate high school, leading to lifelong earning gains of, at least in developed world, in US and Canada, over $250 US. So cost of inaction, on the other hand, if we don't do anything about it, children growing up in poverty without the support lose up to 20% in their lifetime earning due to reduced cognitive development and poor health. Poor nutrition alone in early childhood can reduce adult wages by more than 10%. At the government level, there are gains and losses. Obviously, the gains would be increased spending on child health, education, protection, see GDP growth through a more productive and healthier workforce. UNICEF and the World Bank estimate the scaling up child-focused intervention in low, middle-income countries could add up to 3% in GDP. 3% up or $3 in GDP for every $1 spent. So again, investment outweighs the costs. On the other hand, the losses for inaction, underinvestment in children, nutrition, education, protection leads to productivity losses equal to 2 to 3% of GDP annually in some low and middle income countries. In sub-Saharan Africa alone, stunting across alone contributes to 25 billion in losses annually due to reduced productivity and increased healthcare costs. A 1% increase in child mortality is associated with a 0.15% decrease in long-term economic growth. So my key takeaway, we have global commitments in education, health, social protection with a floor, but we don't have one for child rights and child protection. So education, in General Declaration, each country is committed between 4 and 6% of GDP, or 15 and 20% of their public expenditure to improve status of education. That's like kind of a benchmark. Anything below, the countries are supposed to meet that threshold. In health, we have the Abuja Declaration, which says that 15% of the annual expenditures need to improve the status of health. In social protection, between 5 and 7.5% of the public expenditure, or minimum at 3.3% of GDP, is the threshold, but there is none in child rights and child protection. So there's nothing yet defined, a global commitment. It would be good to have one in the future, and we hope to get there. Thank you. And I'll stop here. I'll invite the next speaker, and questions and answer we'll take. Please, you can write them in the chat and we'll answer them right after. So next is Dr. David Akpan, and he will be talking about the investment in children living with HIV in Nigeria, barriers to pediatric HIV treatment and healthcare access in Nigeria. Over to you, David.
Yeah, thanks. Thanks so much, Sheriff, for setting the stage for the conversation. I think those, I mean, kind of set the tones for the conversation, basically, and you point out what it should be. So driving this back, maybe narrowing the conversation primarily to looking at children living with HIV and how investment could either improve access or become a barrier to pediatric HIV treatment. So we'll look at this closely. Next slide, please. So we'll start with, next slide, please. So we'll be looking at the situation of things as regards CLHIV, that children living with HIV in Nigeria. And we'll also then we'll be looking at what is the financial landscape, what's the cost of inaction, and what then is the investment case that we're trying to make. So next slide. So let's look at the situation. So regionally, we look at some of the outlook that it looks like. It does show that there are a lot of contribution in terms of HIV infection for children across the region, and in Africa, sub-Saharan Africa contributes largely to a significant number of children living with HIV, and that increases the burden of children living with HIV in Africa. Next slide. But if you narrow that down to Nigeria, we could likely say that between the age of, children, which actually the children age 0 to 14 living with HIV, it's estimated that 160 of them, 160,000 of them are actually HIV infected. And then as at 2025, that's this year, only 43,000 of that number are currently in treatment. That's basically just for one funding mechanism, which is just the USAID project, which implies that we have about 116,711 children living with HIV who are yet to receive treatment. So Nigeria it's achieving a viral load suppression of 84% as at this year, which is still below the acceptable UNAIDS and PEPFAR benchmark, basically, which puts it at 95% virally suppressed target. If we look at the chart shows what the treatment gaps looks like, and we could see that these are states that kind of like the high burden states, and Benue topped the chart. And to some extent, it also have the highest treatment gaps as far as children is concerned. And you could see other states as well. So it does mean that there are a couple of issues on ground as regards children living with HIV. Next slide, please. So other, the children living with HIV related health issues, because children living with HIV are actually part of the child population or the children population as far as Nigeria is concerned. So they constitute the population of children who are also poor, could be regarded as poor, and they also face a number of other illnesses, right? And as at 2021, HIV and 9 other diseases had actually been, mentioned to be a part of the 10 major cause of death among children age under 5 in Nigeria. Statistics also further talks about the fact that children population is growing rapidly. So which means that as the population grows and without any sort of intervention that looks at the population, addressing the issues and the challenges of this particular subpopulation, then we are actually most likely setting the country in not so good direction. Other numbers have also, or evidence have also shown that significant number of these children are basically residing in rural environment. And referring to the chart, you could see that rural poverty is actually predominant across all of the regions in Nigeria, and that increases the burden for healthcare, especially for children. Nigeria also has the second highest burden of stunted children in the world, and with a national prevalence of 32% of children under 5 who are stunted. And interestingly, again, 73% of those children who are stunted are actually in the rural environment. So that still, increase the burden of care for those population that are also experiencing poverty. An estimated 2 million children in Nigeria suffer from severe acute malnutrition, but only 2/3 of every 10 child, all right, is currently being reached for treatment, and it's a huge gap to talk about. So with all of this issue, what does the financing landscape looks like? Next slide. So if we look at the investment pipeline that targets children, we've seen that external funding actually is significantly higher than domestic funding. It's very obvious to it. So, but if we then take a look at the public sector funding, or what they call domestic financing, we've seen that over the years, Nigeria has a consistently shortfall of the 15% Abuja Declaration, and up till date, it's still a struggle at achieving the 5% budget allocation for health, and that becomes a problem. And even within the 5%, a lot of funding goes to infrastructures, right, and maybe health workforce. So there's limited, allocation to service delivery, and that then flip, the situation, putting pressure on the Nigerian population to begin to spend out of pocket for their healthcare needs. And like we've talked about in the earlier slide, poverty, in that particular setup actually, give families, a reason to prioritize or deprioritize healthcare and create more problem in itself. So we could see that analyses have shown that over 72% of total health expenditure is coming from out of pocket expenses, and that's a real concern to bother around. So we moved it looking at external funding again. Next slide. We could see that PEPFAR actually, it's one of the biggest or the largest HIV donor or funder in Nigeria, supporting about 90% of Nigeria treatment burden. And from 2020 to 2024, as at last year, you could see an increasingly amount of money that USAID had voted into supporting health program. And actually a decline of that started off right from 2024. And the picture, of course, became worse as we moved into 2025. So over the last 5 years, USAID itself had, contributed a huge sum of money to finance health program in Nigeria, and all that costs across malaria, HIV, maternal health. But looking beyond 2025 with the review of USAID funding, it does mean that Nigeria HIV and health program will suffer some financial downtime, because there's a critical kind of like non-complementary gap that hasn't been closed with the public financing sector as well. Next slide, please. So what's the cost of not doing anything? It will mean that we'll definitely be talking about an increase in new HIV infection among children, and it's estimated at about 2,000 new infections almost annually, and a cumulative 130,000 new HIV infection per year. That's for adults, and that's really huge worry. And statistics also show that significant number of even adults that will be infected, they are more of women of reproductive age, which definitely have a tie with children in itself. There will be actually a significant gap in HIV treatment, which about 73,000 of children infected with HIV who are yet to get treatment. It means as infection increases, then the treatment gap also increases. We currently have 43,000 children currently on treatment. That means that with a stop or a reduced financing and not an increase, no increase in domestic financing, then it means that treatment for CLHIV might be discontinued or might be challenging. So how is Nigeria prepared to sustain the gains that have been made and then close the financing gap? It's something to really speak about, and policymakers or decision makers in terms of investment needs to discuss it. Next slide. So what investment case are we really making? So first, we look at the fact that there are unmet needs for children, living with HIV in terms of what the coverage looks like. And these are kind of high burden states in the north, and there are about 5 other high burden states in the south. And what it shows definitely is that the treatment gap in itself hasn't even been achieved. And to that extent, it means that a lack of investment or a decline in investment will actually expand the treatment coverage gap for children. So our call here will be that a global agenda to prioritize investment in children living with HIV is important. The national government should increase domestic financing by allocating and funding, achieving the Abuja Declaration of 15% of health budget, at least even having a significant percentage of that to child health. Nigeria should review the cost and mobilize investment to provide HIV treatment for over 116,000 children who are in need of HIV treatment, and the 43,000 children living with HIV who need to be retained in care and achieve virus suppression. And of course, the private sector should really come in there to allocate resources to address issues around provision of essential drugs and ARVs for children, vaccines for under 5, and other commodities. I think that's where this wraps up. Yeah, thank you so much.
With that, we would conclude the case of Nigeria. Please go ahead and put your questions in the Q&A, and we'll be able to share them, the responses with you in a short while. Meanwhile, I'll invite my distinguished colleague, Fikar Salam Getinet. She is a gender specialist for education, and she'll be presenting the case of National Costed Roadmap to End Child Marriage and FGMC in Ethiopia, and the way forward after this stage. Over to you.
Thank you so much, Shar, and also welcome colleagues, participants for this timely and critical discussion. Next slide, please. So my next slide, please. So I will be giving you the general background, starting from the global into where Ethiopia is currently on female genital mutilation, and in some ways also child marriage. And I will go to what the government of Ethiopia has done to make an investment case and to cost the interventions that are required. And also at the later stage, I will be talking about the lesson learned and then the way forward and the call for action. So as you know, female genital mutilation is a grave violation of human rights, which involves removing partial or total removal of female genitalia for non-medical reasons, which brings a lot of suffering and a lot of health complications and long-term health complications for women and girls. And around 200 million women alive today have experienced female genital mutilation. This is globally. And as you can see that this number is until 2022, but with the increased number of population and the cost of inaction is also making us pay, making us bring a lot, again, new cases developing. Next slide, please. So when I come specifically to Ethiopia, about 65% of girls and women in Ethiopia, which is accounted for 25 million girls and women in the country, have undergone female genital mutilation so far. And the estimates, the evidences suggested that about 2.9 million girls per year are at risk of undergoing female genital mutilation every year. When we come to child marriage, 4 in 10 young women, which means about 42% or 15 million child brides resides in Ethiopia. Again, this is also, and you can see that out of this, 6 million were married before the age of 5, and you can imagine, what is happening in Ethiopia. And because of this, the government of Ethiopia is very much committed to end harmful practices in general. By 2025 or by 2030 with the SDG target 5.3. And in 2004, the government of Ethiopia has criminalized both practices, and immediately after that, the anti-harmful practices strategy was developed, and some activities were happening. But as Shar earlier said, there is no commitment for the government's investment commitment for the government for child protection. So what was happening was not as such moving. So we needed to scale up and accelerate our efforts based on these findings. The government of Ethiopia launched in 2020 a 5-year national costed roadmap to accelerate action to end child marriage and FGM. Next slide, please. So the globally agreed and tested pillar strategies and core approaches to ending female genital mutilation are prevention, protection, care and treatment, and program support, which has an intervention of empowering adolescent girls and their families, community engagement, including media and religious leaders, enhancing system and service across sectors, strengthening an enabling environment and accountability mechanism, and generating evidence and increasing uptake so that to end the practice as per the commitment from the government. Next slide, please. So a study done by UNFPA and UNICEF has prioritized 31 countries, which has a high number of high number of prevalence from all the countries. Most of them are in Africa, and Ethiopia is one of the the high prevalence countries, and categorized and prioritized these countries in kind of two high level categories. Specifically for the investment. So most cost effective countries would be with a high approval rate of FGM, or acceptance of FGM, with a low decreasing rate of the practice. And still cost effective countries are high level of approval, but with some trend of change has seen throughout the years. And a kind of a 10 years trend analysis shows that investment cases for these high approval and weak trend countries varies from $3 to $469. But for the low approval and the strong downward trend countries is varied from $18 up to $8,000, which Ethiopia is falling currently because of a high number of population, which makes it the persons affected with female genital mutilation is high in number. Next slide, please. So based on this situation, what Ethiopia has done in 2020 is developing a 5 years costed roadmap with the strategies and approaches and interventions with investment needed for 5 years, which is by then 94 million USD. The one you're seeing in the table is with Ethiopian birr, so it is USD 94 million. The funding mechanisms and how government can increase their investment at least by 10% every year. And the priority levels attributed to the different activities, which is if everything goes well, we will do all interventions. If something, some challenges happen, we can do priority 1 or priority 2 activities, something like that. And with result framework also to result the tracking for the 5 years. Next slide. So the midterm or the second year expenditure analysis by sector shows that from the only for at the federal level, at the ministry level, it's 7% of the budget was expended, which is a good thing. However, in some sectors, as I said, it's multi-sectoral. So in some sectors, there was high expenditure and investment made, and yet the indicator, the programmatic, result tracking shows that the indicators are only partially met in some areas, and in some areas it's not met. Hence, the expenditure is much higher, but what actually we have done on the ground is not as much higher. So next slide, please. So what this analysis also find out is that as I said, there is no commitment from the government, or there is a very little commitment for child protection, and for some sectors 100%, for some sectors up to 87 or 62% of the expenditure done in 2 years was from the development partners, which passes the off budget channels from the government, which makes it very challenging to track. And the federal expenditure, the 10% commitment was not also met as such. And this has made it, the diversity of sourcing, the indiversity of sourcing made it challenging the sustainability. So next slide. Also, the trend analysis from this, the same study suggests that there are expenditures, especially in the first and second year of the launching of the roadmap. Everybody was encouraged and then started investing, but different challenges. I'll come back to it later. Different challenges and high rate of inflation in Ethiopia makes it very challenging to achieve what we have planned with the planned, cost of investment. So the increased inflation and other challenges makes it very difficult. So next slide, please. So the key challenges were one, it involved 6 ministries, 6 sectors, including health, education, women affairs, justice sector, and so on. So there was the coordination and the collaboration was not as expected. It was very weak. The limited budget allocation, especially from the government side, from the public finance, was very low. The internal capacity of to monitoring and assuring implementation from the mandated ministry, which is the Ministry of Women and Children Affairs, were very low. Limitation of data tracking, and finally, different emergencies, the internal conflict, COVID, climate change, and so on has affected the implementation and the changes that we were expecting. So as a way forward, we are still trying to coordinate and collaborate better. Based on that, there is a high-level National Alliance to Ending Child Marriage, which is working very hard to make this happen. Capacity development, resource mobilization, data tracking is the way forward. Next slide. And the key takeaways from this is that because we made it clear for the stakeholders that the investment need is this, and this is, if we do this, we will achieve this. There was a growing interest from the development partners, but for the 2 years, few activities were implemented. There was a high inflation, and we needed to account the high inflation, and also the source of financing is highly skewed towards the development partners, but this could be both the opportunity and somehow a challenge for sustainability. Next slide. So I want to end my presentation with this slide as at a global level. To end the practice according to SDG by 2030, we need 2.5 billion USD. And this is for prevention, protection, and care. So if we also focus on specifically on prevention, this is a sustainable way because you are changing minds. You are, agreeing with people who were practicing FGM not to do it anymore. So if we properly invest on prevention, we will be ending the practice once and for all. And for the policymakers and for all also, this shows how much we want to, we want to do. This is at a global level for the 31 countries that I said. But for Ethiopia, we will need 124 million, and we also make this clear for the government and also for the development partners. If we want to end this practice once and for all, we need to invest. We need to invest, and we need to invest very highly. Thank you so much. Over to you.
So thank you, Fikr Salam, and hereby I'll invite the next speaker, Zuzana Ferganova, Social Protection Specialist with UNICEF Slovakia Refugee Response Office based in Bratislava. She'll be explaining to you the case of Slovakia in support to Ukrainian refugees, integrating social services for refugees, migrant children, and caregivers in the upcoming 2026 budget formulation process in 5 major cities: Bratislava, Košice, Trnava, Prešov, and Nitra. Over to you.
Thank you, Shara. Thank you for giving me a floor. Thank you for introducing the topic that I will be briefly talking about. So we can jump right next to the next slide. And so to give you a little background about Slovakia, since we have 5 neighbors, Poland, Czechia, Austria, Hungary, including Ukraine, we were directly affected by the war in Ukraine since its outburst in 2021. But let's start from the very beginning. So since we're located in Central Europe, we're a member of European Union since 2004, and we have a population approximately 5.4 million. So since the beginning of war, there were over 130,000 refugees coming from Ukraine, and who hold a temporary protection. But generally, over 2.3 million crossed the border from Ukraine to Slovakia since the start of the war. So let's go to the next slide. So I'll be talking a little bit what kind of measures government took and what kind of policies were introduced. So the government of Slovakia intervened to support, host, and facilitate the integration of Ukrainian refugees, jointly with regional authorities, municipal governments that I will be talking a little later. But the huge support was done by civil society organizations. Without their support, I'm afraid it wouldn't be possible. So the support from NGOs was very significant. And so in 2022, the European Union activated the Temporary Protection Directive to protect people fleeing Russia's war. And in the same year, meaning Slovakia, adopted so-called Lex Ukraine, which was a package of laws regulating residents' access to labor market, education, transport, social protection, healthcare, and so on. Next slide, please. All right. So, of course, the numbers in comparison to other regions are significantly lower, but what is more important is the percentage here, right? So when we look at the percentage, there is around almost 32% of refugees residing in Bratislava, which is the capital of Slovakia, and of which almost 28% are children. Now, in other 4 major cities, Košice, Nitra, Prešov, and Trnava, which we were supporting through our work plans, UNICEF work plans, the percentage is as follows. You can clearly see the numbers. So in Košice, there was a 7.4% of refugees, with a significant number of children, 35%, and then the percentage goes down in other municipalities. But still, it was it meant to be a big influx, which we barely expected. All right, so the policy directives. Policies have fiscal implication that went beyond what EU has allocated for education. National government has allocated for initial protection, and the subsequency was that the burden fell on regional authorities and municipal governments. As I mentioned before, the relevant support package, including the complementary state funding for families with children arriving from Ukraine, included the healthcare, housing and accommodation, cash transfers, access to education, and subsidies to support children's meal and school. Next slide, please. So here is the status quo. So coming or looking at the 2023 and 24 and 25, those years was almost entirely burden of Slovak municipalities. The municipalities have been using their budgets, allocations for social services to support all Ukrainian refugees. And there has been no additional resources provided to municipalities through existing intergovernmental financing mechanism to support the increasing demands for social services. And those municipalities, those cities that I was mentioning earlier, have been providing physical space needed for additional service, such as blue dots, in case of actually not only Bratislava and Trnava, but in fact, all those municipalities. And through also UNICEF support, those blue dots spaces where we're providing, or still are, in fact, language support, translation services, social services, legal advisory even. So the support was quite complex. But again, still the support has been heavily reliant on development partners. Municipalities are constrained with tight fiscal space and tight budget. And of course, there is always space for discussion for additional revenue collection. Let's go further. So Shar, maybe you can jump into the direct allocation when it comes to different services, and then I come back to what was provided through UNICEF.
Sure. So financing surpassed 100 million for Bratislava within 3 years. As you can see on the left-hand right corner, there is annual allocation per year in euros. So you can see 2022 immediately, then central government pledged, then regional government pledged funding, but also EU came up quickly with support. On the lower left side, you can see the upper line is the government sources of financing coming from the government. So out of 35 million, 29 were provided by the local government in 2022. and 6 millions were provided by development partners. Moving onwards, out of 43 million, and that's where the peak was, 38 million were provided by the Bratislava government, regional, municipal, but also national government. And only 4.7 millions were provided by development partners. Still, with this as well, still remains very critical in terms of financing. And then the financing slowly declines as people are integrated. They have rights to jobs, rights to access to labor market, and they can self-sustain. So the idea behind this was the intervention was to check how much was funded for Ukrainian refugees, but also to check on the sustainability issue. On the right-hand side, you can see the composition by type of government who's contributing. So development partners, they stepped in with 18% in year one, then it slowly declined into 11, 7, and 2.1%. Whereas the remaining parts were from national, central, or municipal governments. So overall, education was the most heavy sector financed due to, and this was Euronormative per capita funding that was provided by partially by EU, but the remaining bit. So this was almost education, but the remaining were other sectors as well. So health falls entirely into the burden of the local authorities and regional authorities, where social services, cash transfers, registration, and accommodation would fall also. It's worth noting that these are only what could be tracked, but there is also intangible, let's say, accommodation that were provided to refugees. On top of that, Blue Dots facilities that were provided for free, and this is not accounted in this one. So the numbers are even greater than 100 millions for Bratislava. And the fact that there is also communities and CSOs and NGOs have provided, and people as well, and business community has provided more. So that's not part of this. The same goes for the other smaller towns. Košice, being the second largest city, surpassed 21 millions within 3 years, and the same patterns. Education being the biggest, and the only difference is that the donors kicked in 2023, but then they slowly decline in 2024, and then they almost cease to exist in 2025, and this is an estimate. The same goes for Prešov municipality and for Trnava municipality as well, and Nitra as well. So the similar analysis was done for all of them. And here I'll give you the floor. Over to you.
Yes, thank you. So coming back to UNICEF support, these are the numbers for the last year. So I'm gonna go briefly through them. So as I mentioned, the Blue Dot centers, there were more than 10,000 people provided access to safe spaces in those centers. More than 62,000 people received information on prevention and access to services. I mentioned that there were 5 centers open in total in those 5 different municipalities. And in order to sustain the support and for future, there were 4 strategies developed for refugees and migrants within those municipalities. And over 15,000 Ukrainians and host communities came together last year through various community events and small projects that we supported through grant schemes in Bratislava, Nitra, and Prešov. And over 7,000 children had access to formal and non-formal education. And more than 53,000 of Ukrainian children and caregivers were reached. So again, within the Slovak context and Slovak population, these numbers mean quite a significant success. And now looking from a higher perspective, I think this is the last slide, Sharp, am I right? Okay, so I'm going to conclude with the higher perspective. So there is an ongoing debate in Slovakia, not only in terms of how we are providing support to Ukrainians, but since there have been few years since the war started, now the narrative shifts to how we are using the international talent that Ukrainians brought with them. And since the talent pool has increased because of the ongoing conflict in Ukraine, how we're using the potential. And unfortunately, this hasn't been solved yet, and it's still ongoing debate. Also, in the context of brain drain decrease in these regions, which is expected to be 21,000 by 2030. So this is a very, very important information, not only to Slovakia, but also in terms of wider European context. So this is probably something that won't be solved today or tomorrow, but it's a very important question to deal with in the nearest future. Thank you.
Thank you, Zuzana. And I would like to invite the last speaker for today, Dr. Neha Singh. She's the Serious Nutrition Co-Cluster Coordinator for Save the Children. And she'll be talking about the hidden price of hunger, the cost of inaction on malnutrition in Syria, and what needs to be done basically to mitigate that issue. Just for the reference, please submit your questions in the chat, and we'll get back to you we have your credentials, and we'll get back to you with the answers as soon as possible. So over to you, Neha, Dr. Neha.
Hi, Shar, and everybody else. Just wanted to confirm if everybody can hear me. I'm kind of in a low
We can hear you loud and
internet
clear.
zone.
Thank you.
Brilliant. So I don't see the slides on the screen, Shar. Can you project them, please? Yeah. It's, of course, a very difficult act to follow after all the brilliant speakers that have created a case. I will just like to give a brief background first about the Syria crisis and the Syria situation. Next slide, please. So basically, Syria crisis started 14 years ago, and the overall situation of Syria was always considered to be a chronic malnutrition, anemia kind of crisis up until 2019. What we started seeing after 10 years of a protracted crisis was a dual burden, which had the components of very high stunting rates amidst children and very high anemia rates and micronutrient deficiencies amidst mothers. And that was also followed up by an increasing rate of acute malnutrition, which kind of means wasting amidst children and mothers, primarily due to the existing stunting and existing micronutrient deficiency crisis. So if you look at the overall population burden, there are 16.7 million people in need as estimated by the UN OCHA estimates. There are 11.1 million vulnerable residents. That kind of means that 92% of the total population of Syria currently is estimated to be either in need or is estimated to be a vulnerable resident. And if you look at the overall ask in terms of $1 billion, it is approximately $2.04 billion. That was the ask for 2024. For nutrition, if you look at the overall burden from those 16.7 million, 6.4 million are in need of the nutrition sector response. Out of those, there are 1.3 million children approximately who are undernourished, and there are 1.3 million mothers who are either anemic or undernourished. And that is then further complicated with adolescent girls that are also undernourished and having micronutrient deficiencies. Next slide, please. So overall, I will not go through every detail of the entire crisis and the numbers that are already there in the presentation. What actually needs to be understood about the Syria crisis is that Syria actually was a first world, very highly efficient education and health system country 15 years ago. So the transition in Syria and the brain drain in Syria and the overall protracted crisis in Syria had then led to currently emerging third world crises, so to speak, like measles outbreaks, vaccine preventable diseases, diarrheal outbreaks, water scarcities, health infrastructure failures, and non-availability of health personnel as well as nutrition personnel in the field to actually provide the services that need to be provided to the population. So there are poverty and economic issues that are complicated with food insecurities, complicated with wash challenges and water-related scarcities, water preventable diseases, vaccine preventable diseases, and waterborne diseases. And that then led to an increasing trend that we started seeing in 2019, which has become a huge problem and is now an outcome of the failures of the existing challenges that existed previously. So even though the global malnutrition rate, which is actually an estimate that nutrition does for the total number of, population estimate of how many children we are expecting to be malnourished, remains under 10%. There are areas and pockets within Syria where this GAM rate actually is more than 15 and between 15 to 20, which is an emergency level of malnutrition. Next slide, please. So what we did when we started seeing, and this is an example that I wanted to present because, there is a huge challenge in front of us. We need to do the best utilization of the available resources. We will never possibly have, all the functional elements of all the systems that need to be done. So what we proposed as a solution was a multi-sectoral area-based equity-focused approach, which also, in terms of what Shar had presented, is a way of, doing more with less amount of money. So it's more effective and efficient ways of working. Next slide, please. This model actually was developed to utilize the existing machinery within the health system, to utilize the machinery of the nutrition system, because previously, before 2019, and it is only in Northeast Syria that this model has been implemented so far, the only existing program that was being provided was the infant and young child feeding program. There was a parallel system of health facilities which were delivering primary healthcare center support. And so what we did was that we integrated these two systems. We trained the health personnel and the nutrition personnel to deliver a malnutrition treatment service integrated within the existing health systems and also providing counseling support throughout the same cycle with an attached system to a community level component. And then, of course, there is that referral challenge. And for that referral challenge and to support the mothers, there was a cash voucher assistance that was added on to that program, providing the whole social security complex to a child that is malnourished so that the child recovers, not just survives, but thrives. Next slide, please. I will not go into the numbers. Of course, the program was successful, but what I wish to highlight here in this slide is that most of this support was provided through a USAID BHA funded grant for approximately 4.5 million people in Northeast Syria and a similar number of people in Northwest Syria. And all of that changed in December when the shift started and the funding cuts were announced in February. Next slide, please. So basically, through that program, with an investment of $150,000 US, 24,000 children and mothers were reached through 6 different partners across Northeast Syria. And all of this support is now conducive only till June. So post-June, we really do not know how we are going to continue the treatment of these children, how we are going to provide services to these mothers, and what is overall going to happen to the safety net of health services, as well as the supply chain that was developed through that process. Next slide, please. So what also needs to be understood, as I began with, the current situation in Syria, moving forward, next slide, please, is about a multi-sectorality of the nutrition crisis. Nutrition alone cannot be, we cannot actually solve the nutrition crisis by providing nutrition-specific response or treatment services. Nutrition can only be managed if you actually strengthen the health systems, you provide safe water to the child at the level of the household, you are able to provide vaccines to those children, and you are able to treat micronutrient deficiencies and provide minimum dietary diversity to the child through the food security nexus that exists. Because all of those nexuses were failing, we were forced to prioritize because there was never enough money and funding available for the past 3 years. There were multiple crises originating. Even currently, you are looking at Gaza, you're looking at South Sudan, you're looking at Sudan, and you're looking at Ukraine crisis right around the area where Syria is located. So we had to prioritize. We identified the nuke areas. We made an area-based prioritization of services. That all is dependent upon the current funding. And so for us, we are looking at a very grave challenge where health infrastructure is not sustainable. The wash services are impacted. Food supplies are impacted. And so the children are any which ways going to be more malnourished. And the challenge with malnourished children is the infant mortality is only impacted by those malnourished children because they are very close to mortality and morbidity. Next slide, please. So this is an example of a wash and nutrition integration. Next slide, please. This is an example of a health and nutrition integration. So every level of health system needs to be having an integrated response of nutrition to be able to comprehensively provide a child-centric approach, which we also, engulf mothers into that child-centric approach and call it as a beneficiary-centric approach. Next slide, please. What I wish to highlight in this particular session with all of you is that when we talk about children, A, those children cannot be talked about in isolation. B, we cannot actually provide services to children without providing networks that actually sustain the population services, that prevent mothers from falling sick, that prevents mothers from being micronutrient deficient, and that also provide children with a safer environment where they can not just survive but thrive. So for us in Syria, when we look at a child-centric approach, we actually need to look at early recovery interventions. We need to look at poverty and child poverty specifically. And we need to understand that infant mortality indicators of the SDGs cannot be met until and unless your infants are surviving, and your infants cannot survive until and unless you are providing that protective environment where the child is born for the first hour, which is called the golden hour, and for the first 6 months. And all of that is why we have this quote in Syria, and we say this a lot to all the practitioners, and whenever we advocate, exclusive breastfeeding is not just a nutrition intervention. Exclusive breastfeeding is actually, for the first 6 months, food security for the child. It is health for the child. It is protection for the child. And it is a way of developing the brain of the child and the bond between the mother and the child, and has proven to be the single largest infant mortality reduction measure across the globe already. So the investment and the cost of inaction has to align with the centrality of nutrition and having a multi-sectoral support for that child to be able to survive and sustain. Next slide, please. I think I've already captured most of it. I think we can just go to the last slide, Shar, if that's okay. So, so just to wrap up and give it back to Shar, I think what is very important for us to understand for the Syria context is that December saw a change in governance. It saw a huge gap that was unraveled to the world. And then February saw a drastic funding cut, which then led to an already fragile system, both for health, for education, for protection, for nutrition, for food security. And the sanctions continue to stay. So there is no way that the internal public financing system, which is already bankrupt, can actually sustain and provide services for the people in need in Syria. Thank you.
Thank you. With that, I would like to conclude the panelist discussion. And can you see? Okay, let me just stop sharing the notes. And I'd like to answer a question that was put in the chat by Jay Hayes. If safety and protection wrap around measures and achieved that when technical or soft skills are necessary for children to acquire to contend with artificial intelligence the 21st century workforce demands. Let me start by saying that in the time when overall financing for children and for child rights was primarily dependent on development partners, namely coming from US government funds, it's important to highlight that all of that was, in a nutshell, 70%, about 70% of the financing of what every country in the world had for child rights and child protection. So, with even without that cut, the financing for children was severely underfunded. Now, with that cut, a budget cut and financing cut, we're risking to basically to sustain the existing level of services, and as we said, mostly we're talking about the response services, not the prevention services. To answer your question, Jay, it's very hard at this time around to talk about the 21st century AI workforce when we're facing existential questions about cuts on let's say you saw in Syria, in Ethiopia, in Nigeria, where the dependence was high on US government funds, but for financing as well. And it's again, the picture is grim, I must say, and it's not looking good for the sector. However, we remain faithful and hopeful that with a little as we can do to change that, so that we can generate evidence so that we can push the governments themselves to increase their share of financing for children. And this is what we have been doing all along for the last 15 years now to do that. I'll pose one or two questions in terms of to all panelists. So what are the political and institutional barriers to ensure additional financing for children in your area of work? And also, how can government be persuaded to invest more when it comes to children? And what role do we play to help them to invest more? So I'll start with the last speaker, Dr. Neha, and then going backwards with Zuzana Firganova, Fikr Selam Getinet, and Dr. David Ekman. Over to you, Neha.
Thanks, Shar. I think it's a very pertinent question. For me, in terms of public financing, the most important role that the government can play in Syria, because 80% of the health system of Syria was previously funded by, the 80% of the response previously in Syria was funded by a public financing system, the health response. If the government is able to continue funding that health response and integrating and providing primary healthcare setups as a one-stop shop, instead of just focusing on secondary care and dialysis centers and all of those cancer treatment centers, but focusing energies on the basics and investing also heavily in terms of developing the workforce or bringing back the Syrian workforce that has already migrated in the past 13 years, because there are many, many doctors from Syria who are living in different Western countries who can actually come back and actually support in, investing back into Syria and building Syria better, like we call the concept of building back better. I think those are the two most important initiatives that the governments can take and sustain them. But I think globally also looking at sanctions, you cannot buy medicine in Syria. It takes 6 months to bring a paracetamol from outside when a humanitarian partner is trying to implement. There were actually medicine manufacturers in Syria, which were closed down in the last 13 years because of sanctions. There were farmers who were providing local solutions, and none of those is available because of the global sanctions. So I think those are the two-pronged approaches that need to happen so that, Syrians can actually begin to see a change in terms of the economic and the public financing dialogue. Thank you.
I'll ask the other speakers to be brief so that we can be on time. Just quickly, Ms. Firganova and then Ms. Getinet. Over to you.
Okay, I'm not sure you can hear me. I'm sorry, I lost the connection for a while, so I was not able to catch the question. But when, as I understood from what my previous speaker was mentioning about public and private dialogue, and in terms of supporting refugees and migrants, I think it's very important to first of all recognize the situation and the problem. So the fundamental step is to have the recognition and the willingness from the state representatives and the government, regardless of the topic, regardless if we're talking about financing the healthcare, social support, other very important sectors, schooling for migrants, right? And coming back from to what I said before, the talent retention. I think those are the very important and the crucial topics that need to be addressed and addressed properly through policies and strategies. Coming from the Slovak context, it's still a challenge for us. and we need to cover that. So this remains to be a difficult question to be answered still. I
Thank
don't know
you.
if I answered the question,
No,
but
you did. You did. Thank you. Ms. Gettinet, just briefly.
Okay, thank you, Shar. Those are very important questions also for the child protection issue and ending the harmful practices in Ethiopia. So I would say the commitment is there from the government side, but the commitment was not changed or is not changing into, actual investment specifically into money. So I would say two things. One is, for example, for the government, we are advocating that, using for the prevention, specifically using for example, using the government media, the already available platforms to aware people and, to increase the awareness and to engage religious leaders who are really the gatekeepers for this kind of practices. And for example, if they can give 2 minutes per day, or I don't know, 5 minutes, 10 minutes per week from the government media, that could help a lot. We are not really asking in cash, money in cash, but using this kind of the government or government-owned platforms. If we can use, for example, health extension workers who are going house to house to do health activities to add, one component for harmful practices, prevention and protection. I would add one thing is also to do advocating for the investment with the development partners. It's always deprioritized, let alone with the current state that we are in. But even with if there is any small conflict or in COVID, for example, it's always deprioritized and it's considered as, not life saving. But it's bringing for girls, for women, it's bringing a lot of and long-standing complications. So we need to see it from that perspective, and I would encourage the government to advocate for that. Thank you.
Thank you, Fikar. David, please go ahead, Dr. David.
Yeah, thank you. I think I will be quick about that. So for me, two recommendations, and that's a great question. So for Nigeria, I think the government have started off with the sector-wide approach, which helps with harnessing available resources and streamlining them in the right direction. So that is actually something that should really encourage the prioritization of children-funded initiative or health needs for children. So I think that our children should really come at the front burner of that particular approach. The second one, it's around harnessing opportunities with the private sector. So although the private sector seems to be struggling at the moment, but there some very open willingness for the private sector to contribute to social impact. So if the government is able to offer enabling environment, things around tax rebate, which is like a given to corporate social responsibility, contributions by the private sector, that could also drive some form of investment, might be in-kind investment or contribution of resources, especially around drugs, medical equipment, direct services for nutrition for children living with HIV, as well as vaccines. So those are things the government could take forward as an initiative. Thank you.
Thank you all. With this, I would like to just remind you that we've passed the time, but I'll conclude with a remark and then give back to the team, Georgetown University team, the floor. Despite the grim picture, having worked in all the countries where the panelists come from, except for Syria, I believe that there is an opportunity for us to see it on the bright side, the glass half full, where we would use our strength in generating evidence that we have done together to use that to convince the decision makers to release more money. There is money available, but there's just it's bringing people together, and as you rightly pointed out, there is an opportunity and adversary as well, Dr. Neha, where we would need to basically work with what we have and making sure what needs to be done needs to be sustained as well in terms of children and child rights and child protection. With this, I would like to thank you all for all of you that you've been available and spared the time to listen to us. This is just the first out of many to come webinars, so we look forward to seeing you soon. And should you have any questions, please you can send us by email, and thank you all for being part of this discussion. Thank you.